Wait. Before we start, just want to make sure we're clear here. While this podcast talks about sobriety, mental health, and addiction, it is not meant to replace professional medical advice. Welcome to Sisters in Sobriety.
I'm Kathleen.
And I'm Sonia.
And we're ex-sisters-in-law, brought together in marriage and bonded through our sobriety journey.
Join us as we talk sobriety, addiction, and everything in between. You're in for quite a ride. And our Substack is buzzing with amazing content, from creative mocktail recipes to insightful courses and reflective exercises. There is something for everyone. Don't miss out. It's a great way to add some extra joy and depth to your journey. Check it out. Welcome to Sisters in Sobriety. And just a quick reminder to rate, review, and follow us wherever you listen to your podcasts. Today, we're joined by Dr. Kelly, professor of psychiatry and addiction medicine at Harvard Medical School and the founder and director of the Recovery Research Institute at Mass General Hospital.
He has dedicated his career to studying what helps people get sober and stay in long-term recovery, and how we can make those paths more accessible, effective, and stigma-free.
Welcome, Dr. Kelly.
Good morning. Great to be here with you both. Thank you for having me.
We are so excited to have you here. So, what drew you to the field of addiction medicine and recovery research initially?
Well, I got into the field for personal reasons initially, and got interested particularly in the interface between our clinical services and long-term recovery support services, really in recognition of the need to amplify and extend our effects of our clinical treatment effects. So as listeners may know, we have lots of treatment, good treatment services nowadays that we never had before. We have a variety of different pharmacological and psychosocial treatments that operate through about 15,000 treatment facilities around the country. But those treatment services tend to provide really short-term acute care, stabilization, detoxification, stabilization. And most of our treatment protocols are around 12 weeks. So the question, of course, is what do you do then, right? How do you help people sustain remission across particularly the first 5 years after they meet criteria for one of these disorders, an alcohol or other drug disorder? How do you help them traverse the very risky, high-risk period in those first years of early recovery? And so this is where it, in my mind, became very important to understand what are the linkages that we can make in our clinical services to these ubiquitous, free, indigenous recovery support services that are available and growing in variety and scope and type around the country.
So I have a question about addiction being labeled as a chronic disease. We often hear addiction is a chronic disease. When does that framing help or hinder? So I'm just thinking of, when it can feel limiting in terms of recovery. Like, well, I have a chronic disease. And so what do you think?
Yeah, it's a really good question. And again, it can be helpful, but I think it also can be harmful. It really depends on the circumstances. In many ways, if you look up the definition of disease, addiction fits the definition. It is a disease. By definition, it is a disease.
Yeah.
Now, having said that, most people recover from it and get into sustained remission from it. So yes, it can be chronic, it can be relapsing. But most people, 72%, by the best recent estimates, actually achieve full sustained remission from an alcohol or other drug disorder. So that's a high rate of remission for these disorders, which is much higher than other kinds of psychiatric illnesses. So that's the good news. Of course, it can be a very bumpy ride into remission and recovery. And I'm not discounting, of course, the tragic, unnecessary premature deaths that occur because of these disorders. We have to take into account all of the losses and casualties that occur as well. But having said that, most people do recover. This is where the nuance comes in in describing it as a disease or a chronically relapsing disease or a chronically relapsing brain disease. We did a study actually where we manipulated those terms and looked at stigma and whether it was helpful or harmful to use different terms associated with these disorders. And we had 6 different terms that we looked at. One was kind of, and they varied from kind of the more biomedical, Kathleen, to the less biomedical. So they went from describing addiction as a chronically relapsing brain disease, to a brain disease, to a disease, to an illness, to a disorder, to a problem. Okay, so those are the gradations. Now, underlying that, as you can tell, one's kind of more very biomedically loaded. The other one is less biomedically loaded when you call it an addiction problem, let's say, or a substance problem. And what we found was that in some instances, depending on the type of stigma that you measured, for example, the blaming stigma, the kind of stigma that that leads to shame and blame, that kind of stigma is alleviated when you use more biomedical terminology. So when it was described as a chronically relapsing brain disease, people were more sympathetic towards people with addiction, so they had more compassion, more empathy. When you did, and when you described it as a problem, they had less compassion and less empathy. But what's interesting is when you look at another dimension of stigma, which is perceived dangerousness and perceived ability to recover, it was better to use less biomedical terminology. The exact opposite was true. So it wasn't helpful, in other words, to describe it as a brain disease or a chronically relapsing brain disease when you want to employ someone as a babysitter or who has a history of an alcohol or drug disorder. Or when you want to find a job, it's not helpful to describe it in those terms. It's more helpful to describe the disorder in less biomedical terms. In other words, it depends. Hopefully that was somewhat clear what I said there. It's kind of a bit complicated, but
No, that's clear. That's
So
clear.
more in a social realm, is it acceptable to use non-biomedical terms? And I've heard this a lot recently. Like, we're not going to use the words like dirty or clean. We're not going to use like drug abuser, addict. How do you feel about those types of words that we kind of throw around a little more easily?
Yeah, well, what we found out, is that we've done a few of these studies ourselves here many years ago, actually, to really figure out, does it really matter, the kind of terminology? Is it just political correctness? And it doesn't really matter what kind of language we use to describe these disorders or people who have them, or does it make any difference? And we found that some terminology does seem to negatively affect perceptions about these disorders and people who have them. For example, we found that describing someone as a drug abuser or a substance abuser, using that kind of abuser terminology, kind of seems to imply willful misconduct, that they are just engaging in willful misconduct and therefore should be punished rather than treated. Conversely, when you describe that same person as having a substance use disorder, it leads to more perceptions that they need treatment and less likely that they need punishment. So when we randomly assigned those terms describing the same person, randomly assigned the person being described as an abuser versus having a substance use disorder to experts, clinicians in the field who were doctoral level clinicians, they were susceptible to that bias just by merely changing the word to describing the same person as a drug abuser as opposed to someone with a substance use disorder. So very interesting how it can induce those biases even when we don't intend it to. And I think that's what's really compelling about certain terminology. There's been other studies that show similar kinds of effects as well that replicated those initial findings. We did another study where we looked at the same two types of language, the abuser terminology versus describing someone as having a substance use disorder in the general public, and found even larger differences across dimensions of blame, treatment, punishment, all the kinds of things that you would expect to find differences on. We found very big differences. In other words, when the general public hears the term person being described as a drug abuser or a substance abuser, they're more likely to view that person as being more to blame, more in need of punishment than treatment. Conversely, when they're described as having a substance use disorder, it's more likely that the public will perceive that person as needing treatment and less likely to need punishment. So it does seem to make a difference how we frame it. And of course, that framing, that terminology comes from the taxonomy, how we classify these conditions or disorders or illnesses. Should we classify them as a society as criminal justice problems or as clinical problems or public health problems? So this is the debate, of course, gone on for a long time. But we do know that language does make a difference.
Do you think it has an impact, like that stigma or that public perception, how we use the language? Do you think it has an impact on whether or not someone can stay in recovery?
Yeah, it's also been shown to affect the quality of clinical care, how clinicians view people, and how they describe people with these disorders in clinical settings. And it also has been shown to lead to premature dropout from treatment, for example. So when they themselves view themselves as a drug abuser or alcohol abuser versus someone with a disorder, they're more likely to drop out of treatment, even at the same level of severity. So it's not a question of severity being an indicator of dropout. It's rather that people, irrespective of their level of severity and complexity and chronicity of the disorder itself, it's just whether they have that kind of self-stigma, that blame that they attribute to themselves for having the disorder. And this is, of course, where we can make a difference. We can make a difference here in educating patients about the nature of these conditions, what we've learned. As I mentioned, these are neuropsychiatric illnesses in the sense that they affect the brain's neurocircuitry. Chronic exposure changes the brain. And this is what we call it. Radically it changes the brain's neurocircuitry at functional and structural levels. And you can see on neuroimaging images that the brain in chronic cases is severely impacted, severely changed, radically changed. And this, when we see these kinds of things, we can see that the brain has been damaged and has been changed. And this helps us to kind of understand why it is that people have a difficulty to be able to self-regulate the impulse to use despite harmful consequences. In other words, they're using against their will. It may start off as it does, of course, as a voluntary thing, right? People choose initially to use alcohol or another drug. They don't know they're on a path to addiction. Nobody ever planned becoming addiction, becoming a slave to the drug, but that's what happens over time. Not for everybody, but for this proportion of people with particular other vulnerabilities, including genetic vulnerabilities, they're more susceptible to developing the disorder, which ends up whereby they're actually using against their will, where they swear off it, better stop, but they find themselves to stop despite the harmful consequences. And this, of course, is why it is a psychiatric illness, why it's placed in the psychiatric realm. If it wasn't the case, then it would not be in the Diagnostic and Statistical Manual of Mental Disorders.
Yeah. And do you think we're doing enough to educate healthcare providers, or do we need some sort of systemic change in how, for example, like paperwork is managed when it comes to addiction or forms or, in terms of coding or things like that? Are we doing enough, or do you think we need some more changes?
Well, I think we need, we need a ton of changes, Sonia. It's a great question. We right across the board, we've all kind of, been reeling in North America from the opioid crisis, but really that's been happening in the context of other endemic crises to do with alcohol and other drugs that have been going on for a long time. We've seen increases, 180,000 deaths in the United States per year now for alcohol, and over 100,000, around about 100,000 for drug poisoning deaths. Those are just the acute deaths. I mean, there's a lot of course, heartache, misery, all the other trauma that goes along with addiction is occurring as well beyond the deaths and other kinds of illnesses and diseases. And yet we've been behind the curve in terms of really addressing it at the clinical level. We need to do a much better job of training our social workers, our mental health counselors, our psychologists, our nurses, our physicians in screening, assessing, and treating and referring patients who have these disorders to the right kind of care. Um, and historically, because they've been so stigmatized, there's been a lack of emphasis on really addressing these problems, which affect every other area, by the way. They affect every other area of medical care and clinical care more broadly when they're not detected. So they may be present, but you may never talk about it, and it's going to affect the outcomes of your patients, regardless of what they have, oftentimes because people are often have high rates of alcohol or drug exposure. It doesn't need to be very much to influence the efficacy of other kinds of interventions and treatments. So I think we need to do a much better job in terms of training, educating and training our clinical workforce. We're trying to do that right now. We're trying to amp up efforts to make sure that all of our frontline healthcare providers are really better trained to assess and address these types of problems. And then, documenting it properly. I think that was more to your question, Sonia, is how it's documented and the kind of language and the way it's documented. Some people are very sensitive to that. Many people are oblivious to that. They don't realize how they refer to patients who have these disorders, as I mentioned before, how that can actually affect perceptions that they may hold or other people may hold when they see language. Again, language both reflects and affects our approaches to these problems. So we have to be careful, especially when we know now that certain language in particular, as those terms you mentioned, abuser, certainly not, I don't think we need a study to all come to the conclusion from a public and clinical health standpoint that we should not be referring to urine toxicology results as coming back dirty or clean. That kind of street language should not be present in public health and clinical settings. We should talk about negative and positive results the same as we would in any other kinds of bioassay tests that we do in our clinical settings.
On a personal note, I remember when I was struggling with alcohol, I remember being really nervous to get help because I had my dental license. And every 2 years when I would renew my dental license, there were very specific questions. If you've been diagnosed with a mental health disorder, if you'd been, is there anything that could impede your ability to practice dentistry, such as addiction? And so I do remember being really nervous to get help because I didn't want a label. So before we move into kind of talking about AA, how are you defining recovery? And so I know that AA has a pretty strict definition of recovery, and some AA programs are even more strict where if you're taking an SSRI, you're not considered sober. But how do you define recovery, and does that include for medication-assisted treatment? Are people in medication-assisted treatment in recovery?
Mm. Yeah, good question. And I think the field overall is grappling with kind of what is the definition. People have very different ideas about what recovery is or should be, or what should be its active ingredients or component parts. I think about, and there's two ways to think about it. There's kind of a subjective sense of recovery where that can vary between people, among people. Will say, I'm in recovery when I say I am. And that's perfectly fine. And many people do that, of course. But there's another part of this, which is, can we come up with an objective definition of recovery that is measurable, operationally measurable, testable, so that, for example, beyond remission status, because we already have a good definition of remission, right? Remission, which is basically, having no symptoms for a period of time, usually between 3 and 12 months. 12 months is full sustained remission, where you have subthreshold symptoms, usually 0 or 1 symptom. So you're in sustained remission. A lot of people say, well, recovery is more than just remission. But the question is then, what other dimensions should be measured objectively that would classify someone as being, quote, in recovery versus not, right? So there's these two elements, right? There's a subjective, I'm in recovery because I say I am. And then there's the objective, can we actually get prevalence rates on recovery? right, from an objective, like we do with remission status, right? We have very clear operationalized criteria for establishing rates of remission for these disorders. We do not have those same kinds of established criteria for establishing, classifying people as being in recovery or not. So it remains at the moment a question mark as to what constitutes recovery. When I think about recovery, and that was your question, I'm good at very long-winded, circuitous answers. That's good. I'm not trying to fill up time here, by the way. Trying to get to the point here, the punchline as quickly as possible. But the I think about recovery really as remission plus the benefits of remission. So, what I think about is when people get into remission, their mental health improves, their functioning improves, their employment improves, their family life improves, their ability to sleep, all their appetite improves, all the kinds of things, the biopsychosocial elements of their life all improve in recovery. And so I think about recovery as being remission plus what's added. And I think what happens when you remove the poison out of the brain, out of the central nervous system, Mother Nature can do her work. We're not meant to have that poison in our system on board. So when you remove it, then Mother Nature can come in and do what she's supposed to do, which is for the organism to get healthy. And there are certain things that we can do to help Mother Nature out by providing certain environments, certain contexts. I kind of think about, and I've written about and talk about similarities between photosynthesis and psychosynthesis. I think about photosynthesis for a plant. There's only so much you can do to a diseased plant at any given time to heal it, that when you have a sick plant, but rather you have to put it in the right moisture, the right light, give it the right temperature. And over time, that plant will flourish and grow, not just survive, but flourish and grow. The same is true of human beings, I think, is that when we create kind of a psychosynthesis, we create the right kinds of conditions for human organisms. And that is the kind of the social networks, the activities, the nutrition, and the emotion regulation. Those elements are very important for psychosynthesis in human beings to occur so that they can similarly grow over time. And again, there's only so much we can do with a human being at any given point in time when we're treating addiction, right? Yes, we can metabolically stabilize someone. We can detoxify someone over a few days. We can provide some short-term stabilization. But what's next? What do you do next? You have to create the right kinds of environments that human being can heal in successfully. And we can help Mother Nature out by not just removing the poison, but also by creating the right kinds of conditions for that organism to heal and flourish and grow.
I love that comparison to a plant, Dr. Kelly, because I did repot a bunch of ailing plants this past weekend. And now it gives me new meaning when I'm going to look at those plants. I'm like, just like humans, we need new soil. We need some nutrients. Love it. You have some very well-known research on Alcoholics Anonymous. And, we're going to delve into that a little bit more. But what outcomes do AA programs improve most strongly? Is it the abstinence, quality of life, mental health? What are those outcomes that improve most strongly?
Well, what the evidence base shows, again, we haven't, when you look at the evidence base historically as a field, we have not done a good job in measuring the kinds of outcomes that you're alluding to beyond remission and abstinence. So now we do know, of course, anecdotally and from other kinds of qualitative studies and other kinds of prospective quantitative studies, that people's lives improve, right? We know that when people get into remission and stop drinking or using, their lives improve. As I mentioned, you remove the poison, Mother Nature can do her work. There's a lot of healing, there's growth. And of course, that's a major incentive for people to continue in recovery because life gets better. And where we have the most evidence, and this is just in part because the last 50 years we've been focused mostly on things like abstinence and remission status. AA does a much better job at helping people sustain remission over time than other kinds of treatment which
Yes.
people can be randomly assigned to get. So that's the good news. If you want to stay sober, there's no better method right now for alcohol use disorder than linkage to AA. That's the strongest evidence we have in terms of sustaining remission over time.
And I'm going to ask a question now that we may edit out because it might very well derail us. So, Sonia, please don't hate me for asking this question. I am just curious, when we are talking about recovery remission, and you gave the stat at the top of the podcast, I think it was 72% of people are we also including process-related addiction in that, or is that something different?
No, we're not. That's a great question. Good
Mhm.
distinction to make, and it's something we can talk about more because I think we need to, particularly with gambling now becoming such a problem
Yeah.
with more access and availability to that. But no, all of the figures I'm citing, unless I specifically say it's gambling or would be to do with psychoactive substance use disorders, alcohol or other drugs, and it excludes tobacco too, because it doesn't produce impairment.
Great. Thank you for that. Thank you for clarifying that
Yeah.
because I wanted to clarify that for their listeners. I felt like if I was thinking it, maybe someone else was
Yeah.
too.
Yeah,
So
great question. Yeah.
So we touched on this really briefly, and I think it is something I don't know if I'm particularly sensitive to, but pretty aware of, is that AA is really focused on abstinence, right? And so how can you reconcile somebody who has either harm reduction goals, or I even find, I've seen people in some meetings that, when they have a relapse, they're really concerned about going back to their group because they feel like there's a stigma in AA about relapsing. And so how do you
Yeah.
feel about that AA and the focus on abstinence? And is that maybe just helpful that they have such a high standard for what recovery is?
Well, I think that was really born historically out of necessity, because if you look back in the history of Alcoholics Anonymous, it really came from pure desperation. The cases documented in the first 100 cases documented, which in the big book of Alcoholics Anonymous, um, were desperate cases. They were desperate case histories. If you read those, they could not be helped by the regular regimen that was available at the time. So they desperately sought something which they ended up creating themselves that worked for them. But it was all about abstinence because their whole life depended on abstinence. Without abstinence, these were cases that, one drink, you're a drunk. That's it. There was no, they knew that they had to stay away completely from alcohol to stay alive. And I think that's why AA started. That's why it grew. It was really for the desperate cases. Now, if you look over time, though, in the history of AA, and you look at the later literature, like Living Sober, for example, which is a book that was published in 1975, when Alcoholics Anonymous was not 100 people, but over 1 million people strong. So there was over 1 million cases of recovery at that time in 1975, not just the first 100. So when you look at that, that contains, if you look in that text, has a much broader repertoire of ideas beyond, things like, abstinence and spirituality, but it talks much more about a broad repertoire of social, affective, and cognitive coping skills, which people can use to get and stay sober. Now, it's still all about sobriety. It's not about reducing use, even though people, of course, who use AA may for a while decide to reduce use or have episodes of use while they are getting into sobriety and into remission. But AA, its strong suit, you can't have it both ways. You either say it's about abstinence and that's the strong suit, or it's not about abstinence, because that also can be a strong suit for people who don't want, but for people who want abstinence, who want to stop, in other words, and get sober, then AA is there's nothing better than AA out there. If you want to cut down rather than stop, then there are other entities, many other entities.
This sort
to
of
use. Yeah.
your answer falls into my next question, because I was going to ask, are there certain types of people who do particularly well in 12-step or AA programs, or who might not benefit as much? So I would assume someone who wants to just reduce may not do as well. I don't know. I'll ask the question. Are there certain types of people who do well in AA and others that wouldn't?
Mm-hmm. Yeah. It tends to be, as I kind of alluded to, it's a great question. Who's a good fit, a good candidate? It's people who generally are on the more severe end of the spectrum, because those individuals have already found that they cannot cut down and use in safety, for a prolonged period. So for those individuals who are at the more severe end of the spectrum, who find themselves unable to stop, to cut down, to regulate, and in a sustained way, they may be able to do it for a few days or a few weeks or even a few months, but they end up, gravitating back towards more pervasive, intensive use. Those people are a good fit for AA, because it supports complete sobriety. It supports and facilitates complete sobriety. And it does that, as I mentioned, from what we have found, it does that better than anything else.
As another aside, I was talking to my other sister-in-law last night about who we were interviewing today, and said, "Oh, we're interviewing this famous doctor that studied AA outcomes." And we ended up talking about, is the evidence sort of confounded by factors like people who are mandated to be in AA programs? Like, how do you sort of tease out that data of people who really don't think they have a problem, but they're there because they either got a DUI or because they're court mandated to be there? Do you tease out that data, or how does that potentially affect those results?
So all the studies that I'm basing that conclusion from or on are non-mandated people. So these are non-mandated studies. Yeah. So because obviously that's a major confound, isn't it? Is when you're kind of mandated to go and not via the court system. That's a different population. Some of those people do well, some of them don't do well when they're mandated to AA. But for people who are voluntary, who are non-coerced, non-criminal justice system non-coerced, they may be there because of, family wants them to be there, or a spouse or a child wants them to be in treatment or in AA. And it's those folks that are in the studies that we have summarized in a lot of our reviews. So non-coerced. Yeah.
That's interesting. And so for people, for example, maybe like me, who can be at times a little turned off by the spiritual language of AA, are there evidence-based alternatives, and how do their outcomes compare to AA?
Yeah, it's a great question. I think about this scenario, in some ways it's less about relative efficacy than it is about finding the right fit. And here's my metaphor for this one. I ask audiences, do fitness centers work to keep people fit? And the answer is, well, yes, they do. If you got to go to the fitness center and you got to work out regularly. And if you do that, then you will get physically fit. Now, fitness centers know this, of course. And so when you walk into a fitness center, do you just see 40 cross trainers and that's it? Now, it's true that cross trainers will keep you fit. If you work out 3-5 times a week on a cross trainer for 30 to 60 minutes, you will get physically fit. But what happens if you don't want to work out on a cross trainer? Now, fitness centers, of course, know this. So they've got not just 40 cross trainers, they may have 40 different classes. They've got pools, they've got courts, they've got all kinds of activities. Why? Because they want to attract and engage more people in some kind of physical fitness activity. That's their speed, that's their flavor. Now, if you draw the parallel there to recovery, and you think about, we know that 12-step works. That's been shown, proven beyond any doubt scientifically. When you compare subject AA to the same kind of scientific standards as you would any other clinical intervention, it works as well or better when it comes to remission than anything else. So that's good news because it's a freebie. I describe AA and groups like it as the closest thing public health has to a free lunch, because it is freely available, ubiquitous. There are hundreds of thousands of meetings across the country in every community and around the world. That's good news. But if you don't want to go to AA for whatever reason, it's not your speed, it's not your flavor, then we need other kinds of speeds and flavors, just much like that fitness center analogy, that people can say, you know what, I don't want to go to AA, but I'll maybe Smart Recovery or LifeRing or Women for Sobriety or one of these online groups or Reddit, subreddit. I can post stuff on there and get help and get help there. And it's a matter of, once people, again, just like with the fitness center thing, if someone wants to they want to work out in the cross trainer, but hey, I'll do a yoga class, or I'll do a Zumba class, or I'll do some other thing to move myself in the direction of physical fitness. Recovery fitness is the same. So if we can get more options available, which we have now, which is the good news, we have many more different kinds of flavors and speeds of recovery support services beyond 12-step, that people now can say, well, there was only 12-step before, but now I can choose something else that's more my speed, my flavor. Now, people migrate too. So they may start off in one group and go to another. They say, they start off in, Smart Recovery or LifeRing or Women for Sobriety. And then they go to another group, like, they swap and change depending on what their needs are and how they develop, and what they want. They may also go to use several options. Many people do a yoga class and also go to the weight room, right? So people can do not just one, but they can actually engage in multiple types of recovery support services. We did a study, for example, where we found that we had about 1/3 of our sample went both to AA and Smart Recovery. They liked the big social network of AA. They found that very uplifting, very buoyant, very positive, very inspiring. But they liked the cognitive and behavioral aspects of Smart Recovery, science-based aspects of. So again, different courses for different horses.
So what do we know about AA, about why it works? Is it the social support, identity change, skill building, something else? What is it about AA that works?
Well, it's a great question. It's been investigated a lot in the last 30, 40 years now. There's been a lot of NIH-funded study actually to understand the mechanisms. And this was started actually by the Institute of Medicine of the National Academy of Sciences back in 1990, which called for more research on AA and its mechanisms to understand how it works. So there was a flurry of federally funded research which came out, which really demonstrated that AA works in multiple ways simultaneously, and it works for different people in different ways. This is another interesting part of recovery, even within the same recovery support service structure. But let me first say that in general, the way that AA works is quite right. Kathleen, you mentioned the social network. A big part of recovery is changing the social network. I mentioned that kind of plant analogy. You can think of the social network as the soil through which all the other nutrients of recovery are absorbed and exchanged. It's that soil that people need to get those nutrients from other people in recovery, that lived experience, those visible role models that people can see, visibly see, tangibly see their lives improving, as well as hear the message of recovery and the imparting of recovery coping skills, which happens in those social networks. So those elements are very important. Now, when people are in those new social networks, which are recovery-oriented social networks, they drop the negative influences, the heavy drinking drug users, out of the network. They adopt the new network, which is widely available in groups like AA. And through that, that's where they pick up the coping skills, the cognitive behavioral coping skills, the self-efficacy, the confidence, the self-esteem, the improvements in quality of life. All of these things happen as a function of engagement with that new social network. And again, those are peers with lived experience. Some of them have weeks, some months, some decades of recovery. So there is literally millions of years of lived experience washing around the rooms of Alcoholics Anonymous and similar mutual help organizations. If you think about it, millions of years. AA in particular, if you think about, there's 1.2 million members in the United States, half of whom have 5 or more years of sobriety. So that's over 3 million years right there. That's just the bare minimum. Right? So you think about the millions of years of lived experience that is being transmitted and shared through AA, but many other groups that are similar, have a similar idea of mutual support, are also sharing their own wisdom, their own flavor of recovery, wisdom, and experience through, again, those role models of lived experience. So it's multiple mechanisms happening simultaneously over time. It boosts coping skills, it boosts confidence, it boosts motivation and maintains motivation over time. It decreases craving, it decreases impulsivity. These are the empirical mechanisms that have been shown to convey the benefits of AA. So it mobilizes all those kinds of mechanisms, which are the kinds of mechanisms which are mobilized by formal treatment, actually. Same kinds of mechanisms. AA mobilizes those. The advantage of AA when you're treating a condition like addiction, which is susceptible to relapse, particularly in the first 5 years, is that AA does this over time. This is very important. And this is why linkages to groups like AA and other recovery support services are so important for amplifying and extending our treatment effects, is because if you can get people involved in these community services like AA, it tends to remobilize those mechanisms over time, and that prevents relapse. That's what happens is you go to these groups, it remotivates people, it boosts their cognitive coping skills, it boosts their confidence, and so on. It does that week after week, month after month. And that's what's key in preventing relapse. Again, recovery fitness is like physical fitness. You can't do it for a month and stop and expect to be 6 months later. Right? You've got to build it into your lifestyle. People who are successful in remission over time are people for whom they build in a recovery paradigm into their lifestyle, whatever that is, whatever flavor that takes. But the ones who are successful, who stay in remission and build quality of life and resilience, are the ones who are able to do that.
Yeah.
To go on here and talk more about the mechanisms, because we've learned a lot. We know a lot about, for example, how men and women differ in terms of the benefits that people might be interested in.
Yeah. How do men and women benefit differently in AA?
Well, I think particularly for this podcast, because, this is Sisters in Sobriety, right? So it has a female bent, obviously. And what was, really interesting, and we've looked at this, what we call moderators of the effects of interventions. And here we are talking about the intervention being AA and how men and women differ in how they benefit. And so we've done studies on this. What we found is that men and women actually benefit to the same degree from participation in AA. So they derive the same amount of benefit, but the way that they benefit differs quite a lot. Now, what we found is that, for example, for women, the biggest risk factor for women in terms of relapse was their inability to manage negative affect. So this would be depression, anxiety, anger, frustration. If they had low confidence in their ability to cope with negative affect, they had a very high risk of relapse. For men, that was not a predictor of relapse. For men, the biggest predictor of relapse was social self-efficacy. That's confidence in coping with high-risk social situations where alcohol was present. So this could be party, sports events, things like that. So men were very different in the types of risks which tripped them up back into relapse, and women were very different. Now, the way that AA was helping men and women was through supporting them in helping them cope with those specific kinds of risks. So AA for men boosted their social self-efficacy, their confidence in their ability to cope with these high-risk social situations without drinking. For women, it boosted. In fact, it explained about half of the effect of AA was AA's ability to help women cope with this negative affect without drinking, and with, in other words, preventing relapse. So that was the biggest difference we found, that helped men and women very differently. And again, depending on their biology, women have more negative affect just biologically, have more challenges than men at rates 2 to 1 in terms of depression, for example. So they have more negative affect to cope with, but also, the psychosocial factors as well, and life stage factors. There's different life context and life stage factors between the ages of 25 and 55. You have to think about it like that too. What are the kinds of challenges that women face? What are the kind of challenges that men face during that stage of life? What's their life context like? The kind of day-to-day, week-to-week context that they're living in. And then what are the risks associated with those contexts? Because AA seems to be able to confer benefit in different ways depending on who you are. We found similar effects for younger and older people, that that younger people under the age of 30 who go to AA, the benefit again to the same degree as older people, but the way they benefit differs. And we found the same also for severity, addiction severity. So I don't want to spend the whole time talking about this, but we could. This could be a whole.
Yeah, that could be a whole podcast, right?
So, Dr. Kelly, when we talk about that negative affect, are we talking about like a diagnosed mental condition like depression or bipolar, or what are we talking about when we say that?
Oh, so it's diagnosed, more diagnosed disorders in the female population with alcohol or other drug disorders, but also, symptoms as well outside of the diagnosis. So in many of these studies that we've looked at, it tends to be measured dimensionally. So these were not diagnosed cases, but rather people with high levels of depression and anxiety, and which tended to cluster more in women than in men. Men also had this too, but not as much as women. And AA helped women prevent relapse by helping them cope with that better.
Is that also a bit of a confounding factor, that are women with depression, anxiety more likely to experience an alcohol dependence or drug dependence?
It's a risk factor for both men and women.
Oh, okay. Okay.
Mm.
So what are you working on now? So we've talked about AA, we've talked about language. What are you researching right now?
Well, many things. We're evaluating different kinds of recovery support services. For example, peer recovery community centers. We're looking at the utility of those, how they can. These are kind of one-stop shops for recovery. These are places where people can go during the day. They're not residences, but rather places where people can go to access peer support. There's a number of groups happening during the day. It's all casual. Some you have to sign into, others you don't. You can go to all kinds of groups. You can get connected to employers. You can be taught how to put and help to put a CV together, a resume together of your experience. You can be helped to link to employers who, if you're looking for a job, other kinds, you can be linked and help to get other kinds of social services if you need them for men and women. So they're great resources. We're looking at the evaluating, kind of putting a magnitude benefit on those. Another study that we're doing is one particularly that's interesting to me in particular, is my favorite one right now, which is looking at long-term relapse. So what are the factors involved in long-term relapse versus short-term relapse? So We know a lot about short-term relapses when people are starting off in that first 3 to 6 months. They get a week or 2 or 3, and then have a relapse, go back to active alcohol or other drug use. We know much less about the factors involved when people have a year or more of sustained remission. So someone who's got a year or 5 years or 10 years, what's different about that relapse? And so we've been looking at that to understand more about the experience of people and the things that go wrong, if you will, over that long term when people return to have a recurrence of the disorder after many years of remission.
Yeah, we've interviewed a lot of people who have had a relapse after 10, 15, even 20 years of remission, which is
Mhm.
really interesting. So if you could
Yeah.
snap your fingers and change one thing about how we treat addiction right now in the US, what would you change?
I guess the first thing that comes to mind, and this is where I spend a lot of my time thinking about, is how we can amplify and extend the benefits from our clinical services. Uh, I think we've been very short-sighted in the sense that we have failed to take into account and consider the broader clinical and public health infrastructure that is available and that we could strengthen and even build out more to to do what I've described earlier, which is how do we sustain remission? How do we uh, build more cases of remission, sustained remission, as well as accelerate the time to remission? So to speed up the time into remission, how do we do that? Now, what it seems to be, the way to do that is not just to provide our more expensive clinical services, which can be life-saving and are very important, but also to capitalize on that, on those moments where we have patients in front of us, to be able to talk to them about supports in the communities where they live and work that can sustain and amplify the initial effects that were being produced by treatment. Because
Mm.
treatment is expensive. We only have a certain amount of resources available. Um, so how can we utilize these free, ubiquitous, indigenous recovery support services and really stitch together our clinical and community services to build a better infrastructure that can support people, not just acute stabilization, but like I said, long-term remission. This is what we should be talking about. How do we get people into sustained remission to build resilience against relapse and recurrence? And this is where we have failed in the past because we've been very short-sighted and disconnected, and we need to connect the dots here between these two types of services.
More like a wraparound approach with all the services.
Yeah,
Yeah,
exactly.
that's amazing.
And as clinicians, to be thinking more along these lines, and a lot of clinicians are not used to thinking about community groups like AA, other 12-step groups, other mutual help groups, other recovery support services, which are fairly new. They're only coming around the last 20 years. Mutual help groups, of course, been around a lot longer. But to get clinicians trained up and thinking, okay, now I've got this patient in front of me for a week or 2 or 3 or 4, then what? What can I do? How can I get this person into sustained remission? How can I get them to go to the recovery gym, right? How can I get them in some kind of community-based thing that can support them build resilience and remission over time? I think that's, from a clinical standpoint, that's one of the things we really need to do. Now, I guess one other thing is we only treat and see about 20% of 10 to 20% of cases in any given year. So about 80% of cases remain untreated in any given year. Now, those cases tend to be much less severe, as you might guess.
Yeah.
They're much more, they're on the milder end and moderate end of the spectrum. Many of those people don't even perceive they have a problem, even though they meet criteria. The kind of people we see in treatment, of course, and in groups like AA and mutual help groups in general, as well as other recovery support services, as I mentioned, they tend to be on the more severe end of the spectrum. So the question is, what do we do about that 80%, 80, 90% of people who actually still causing harm to themselves? Many people are still driving intoxicated. There's domestic violence. There's all kinds of other problems going on in that population. So how can we reach a population which also adds to the burden of disease attributable to these disorders, as well as economic burdens to many societies. How can we reach those folks? And so I think that's another very important area from a broader public health standpoint, isn't it? Is how can we get to those folks who don't see a need for help? And I think more educational campaigns through the great thing now, of course, is we have this computer. People can access these things online in the comfort of their own home, if you will. They can do self-screenings. They can do, self-diagnosis. They can compare themselves to other people of their own age in the population to see how much they're drinking. So all of these kind of normative comparisons can be very helpful as tools to reach those folks, to let them know that they may not realize they may actually be harming themselves, increasing their risk of cancer or increasing their risk of heart disease or other diseases from alcohol that they never knew about. So these can be motivational factors that can help people to change behavior, move towards better health and functioning.
Yeah, I mean, the screening tools online now are great, but actually that does
Yeah.
bring me to another question, which is, have you done any research about whether virtual meetings work as well as in-person meetings for AA?
No, we are planning. Some of my colleagues actually here at the Recovery Research Institute and the Alcohol Research Group in California are planning more work in that area. They've written a study. Hopefully, we'll get off the ground next year to be able to look at that directly. The comparison between online and in person. For whom that might be a better fit, and maybe when too. Like when in the sequence of recovery. Is our online versus in person. Many people use both. Some people who can't get, for various reasons, can't get to meetings in person will utilize online. So there's all kinds of different nuances there, as you can imagine.
Yeah. Well, Dr. Kelly, thank you so much. I learned so much from our conversation, and I'm sure our listeners did too.
Pleasure, Sonia. Thanks for having me.
And thank you all for listening to Sisters in Sobriety, and we will see you next week.
This was Sisters in Sobriety.
Thank you for listening and being with us today.
If you want to learn more about sobriety and meet your community, find us at sistersinsobriety.substack.com.
Are you a sister in sobriety? Then reach out on social media. We'd love to hear from you.
If you're feeling generous, leave us 5 stars and a review and follow us wherever you listen.
You'll never miss an episode. Until next time.